So I would say that the couple papers that we've done that focus on breast cancer have largely stemmed from a great partnership with the Pink Fund. So Molly McDonald, who founded the Pink Fund, has been a great supporter and has really been very interested in this type of work and just been incredibly supportive with fielding surveys and letting us contact patients. Breast cancer is actually no longer part of my clinical practice, but it was, something that I was doing before. I think what's really unique about breast cancer is you're right that it is so common. So we do have a lot of people who are, out there and able and willing to share their experiences. But breast cancer is also unique in that most of our patients are getting true multimodality therapy. They're typically getting many of them are actually seeing all three branches of our oncologic disciplines. They're getting surgery, they're getting chemotherapy before or after. Many of them are getting radiation. So they're really exposed to many different sort of pieces of our oncologic care. Also unique to breast cancer is that, there are some cancer types where you just get kind of a one-time treatment, you're one and done. Breast cancer is really unique in that some of our patients are getting chemo for a year, right? They're really getting sort of long, drawn out treatments. So it's a really interesting patient population that, yes, there's a lot of patients, a lot of many of whom are very willing to share their experiences. They're being touched by every aspect of oncologic care. They're going through treatment sometimes for an incredibly long time, and they're surviving for a long time and feeling all these after effects and coping and trying to recover from this treatment. So it's a really unique population that's great to study for this topic. Our prior literature, when you screen cancer centers themselves, it seems like about 3/4 of centers will say, yes, we screen patients. But here we have this national sample that, is significantly lower than that. And it's a little bit confusing as to whether we're seeing a difference between, hospital A said, yes, I screen, maybe not every single patient, but we have some system in place versus individual patient as to whether or not they actually got it. There's also, a potential that some of what hospitals or cancer centers are considering screening, patients aren't realizing is actually some sort of screening. So sometimes, for example, there's a CMS question about medication adherence, and a patient may not realize that that's actually a financial toxicity screening question. So there is some, differences between what a broader cancer center or hospital might do versus what an individual patient might see. But I think what's really key to me from our findings is that if we really want to start incorporating something like this really often into somebody's care, I think what we really need to do as a community is really come to a consensus of what are the questions that we're going to ask. So CMS is now mandating for certain categories of inpatient admissions and things that we do some social determinants of health screening of things like utilities, transportation, medication. We have some work looking at the 12th question on a measure called COST, which is a comprehensive score for financial toxicity, showing that that one screening question might actually give an overall full picture of someone's psychological distress. But I think one of our first steps as a community is going to be figuring out what is the right question to ask. How can we find something that's really short, really sweet, can be incorporated into, all the screening questions you get when you go see a doctor for the first time. You're filling out, pages and pages of questions. You need to find something short, sweet that can be incorporated into routine clinical care. Once we as a community identify that, and again, our group is doing some work on a very specific question, we need to take that question and we need to actually look at how it changes over time. So collect it serially in patients who are actively undergoing treatment. Take a look. Are things changing? When are things changing? When should our touch points be where we want a physical person coming in and touching base with the patients? We hear from our patients in this study that it needs to be early on. And then we also know in other work that when there's like a big change in treatment, like you're switching a chemotherapy or something new is happening or your cancer comes back, those are touch points. So So I think as a community, we need to look at identifying how exactly we want to screen, picking the questions, picking what we're actually going to ask patients, and then figuring out how often we actually want to be doing this as a screening question versus having a true person going in and touching base with patients as well. There's also questions about what our threshold should be once we actually get that question, that anyone who has any concern at all, should those all get a person? But what if that's, 1,000 people of a cancer center that has one patient navigator? Now, how do we start to identify what's the threshold where we start taking some action? I think there's a lot of work in that intervention and in that screening space that really needs to move us forward as a field.